Good morning, dear students. Today we discussed about anti-leprosy categories of drugs and what's the need or importance of newer antileprotics drugs and what are the importance of multi-drug therapy in leprosy treatment. So first we go to some brief introduction about leprosy. Leprosy is a serious health problems in the developing countries like India. This disease is mainly infected by this Bacillus mycobacterium leprae. This M. leprae multiplies slowly and the incubation period of the disease an average is 5 years. Symptoms may occur within 1 year but can also take as long as 20 years or even more to occur. This disease mainly affects the skin, peripheral nerves, mucus of the upper respiratory tracts, eyes, and this leprosy is mainly curable with multi-drug therapy. And this leprosy is mainly transmitted via droplets from the nose, mouth during the close and frequent contact with untreated cases. But in untreated cases, leprosy can cause the progressive and permanent damage to the skin, nerves, limbs, and eyes. This leprosy bacillus was discovered by Hansen in 1873, almost 12 years before the discovery of tubercle bacillus. The first breakthrough occurred in the 1940s with the development of medicine dapsone. The duration of treatment lasted many years, often a long time, making the complaints difficult. But in 1960s, the M. leprae started to develop resistance to dapsone, the only known anti-leprosy medicine at that time. In the early 1960s, rifampicin and clofazimine were discovered and subsequently added to the treatment regimen, which was later labeled as multi-drug therapy. To control leprosy, there's a national leprosy control program was started in 1955. And later on this initiation of multi-drug treatment regimen for the treatment of leprosy by WHO in 1982, the program was converted into National Leprosy Eradication Program. The currently recommended multi-drug treatment regimen consists of medicines like dapsone, rifampicin, and clofazimine. The treatment lasts for 6 months for paucibacillary and 12 months for multibacillary cases. This multi-drug therapy kills the pathogen and cures the patient. There are different types of leprosy. This is lepromatous leprosy. Here the cell-mediated immunity is impaired against leprae bacilli. And this cause of disease progresses very rapidly. Extensive bilateral skin lesions contains numerous leprae bacilli. Second type is tuberculoid leprosy. Here the cell-mediated immunity is intact and is characterized by the predominant peripheral nerve involvement with a single or few skin lesions. The bacilli are seen rarely. Plenty of leprae bacilli are seen in the skin lesions of borderline lepromatous. This lepromatous leprosy, these groups are called as multibacillary leprosy. Is borderline tuberculoid, intermediate leprosy. This category is called as paucibacillary leprosy. Different categories of antileprotic drugs. First category sulfone derivatives is dapsone. Next is phenazine derivatives clofazimine. Some of these anti-tubercular categories of drugs shows the antileprotic actions like this rifampicin and etranamide. Some of these antimicrobial agents like ofloxacin, pfloxacin and sporfloxacin, macrolide antibiotics like clarithromycin, tetracycline category like this minocycline. So first category is sulfone derivative dapsone. This dapsone is a diamino diphenyl sulfone, is a leprostatic action. Chemically this drug is related to sulfonamide. In case of lepromatous leprosy, resistance can develop. So this usually combination of dapsone, rifampicin and clofazimine. This combination is used in initial therapy. It is also used with pyrimethamine in chloroquine resistant malaria. The main mechanism of dapsone, its mechanism of action is same as that of sulfonamide, that is inhibition of para-aminobenzoic acid incorporation into folic acid. This mainly causes the inhibition of folate synthesis. This results the cell injuries of this bacterium. This pharmacokinetics of dapsone, after oral administration, it is completely absorbed and is concentrated in lepromatous skin, liver, kidney and muscles. It is metabolized in liver, excreted in urine as gluconic acid and sulfate conjugates. This sulfone syndrome usually occurs in patients of multibacillus lepromatous leprosy with a treatment with dapsone. Usually, sulfone syndrome develops in malnourished patients in 1 to 2 months after starting the treatment with dapsone. Presenting symptoms are fever, malaise, exploitative dermatitis, jaundice, anemia, methyloglobinemia. Adverse effects of dapsones are hemolysis, nausea, vomiting, anorexia, headache, methyloglobinemia, drug fever, allergic skin reactions, rarely hepatitis and agangliocytosis. Main contraindications, this dapsone should not be used in patients with severe anemia, G6PD deficiency and hypersensitivity reactions. CNS side effects are insomnia, paresthesia, nervousness, peripheral neuropathy, psychosis, blurring of visions, headache. These are some other uses of dapsone. In addition to this, leprosy is also used some other uses, like in case of P. falciparum malaria, this is usually combined with chloroprogonil. This dapsone is used for prophylaxis and treatment of chloroquine resistant P. falciparum malaria. Another use in case of pneumocystic urine pneumonia, dapsone is used for this condition, which is common in AIDS patients. In case of toxoplasmosis, dapsone plus cotrimoxazole or pyrimethamine and folinic acid is used. This dapsone is also used in various dermatological disorders. Topically, this 5% is used. Therapeutic uses of dapsone in case of multibacillary leprosy, dapsone 100 mg once a day is used together with rifampicin and clofazimine. In case of paucibacillary leprosy, dapsone 100 mg per day is used with rifampicin. Sulfoxone sodium may be used as an alternative to dapsone not able to tolerate the drug due to gastric side effects. The usual dose for adult 330 mg per day. Next category is phenazine derivative clofazimine. This clofazimine is a phenazine dye used as alternative to dapsone in dapsone intolerant or resistant cases. Usually it is combined with dapsone and rifampicin in the multi-drug treatment of leprosy. Main mechanism of action of clofazimine, it may interfere with the template functions of DNA. Is pharmacokinetics. After oral administration, it is slowly absorbed, stored widely in reticuloendothelial system and fatty tissues. It has a long elimination half-life. This shows the additional anti-inflammatory property. Because of its anti-inflammatory property, its use is valuable in lepra reactions. Other uses of clofazimine in case of Bucilli ulcer, this is a chronic skin ulcer. This is usually administered 100 mg per day for leprosy and M-AVM complex 200 mg per day. These are some side effects of clofazimine: discoloration of skin, red brown to black. Skin lesions persist for months after discontinuation of therapy. Side effects are dry skin, itching, phototoxicity, nausea, abdominal pain, anorexia and diarrhea. This clofazimine should be avoided during early pregnancy, liver or kidney damage cases. Anti-tubercular drugs categories mainly shows the antileprotic actions, like this rifampicin is a bactericidal and highly effective in leprosy. A single monthly dose of 600 mg may be used in combination with dapsone. When this combined with dapsone, it shortens the duration of treatment. If it is given along, resistance develop. Single dose of this 1500 mg oral rifampicin, skin bacilli levels falls to undetectable level in 5 days. Usual dose 600 mg per day, but due to high cost, it is used twice weekly by many leprologists. In developing countries, it is used as once a month regimen. Main contraindications in case of hepatic or renal dysfunctions. Another antitubercular drug is ethinamide. This is used as alternative to clofazimine in treatment of leprosy. But due to its hepatotoxicity, its use in leprosy is very limited. Next category is antimicrobial agents like these fluoroquinolones like ofloxacin, pfloxacin, spotfloxacin. This can be used in alternative regimens when rifampicin cannot be used. Macrolide antibiotics like clarithromycin is effective against M. leprae as an alternative multi-drug therapy regimen. Ofloxacin, this 99% bacilli were found to be killed by 22 daily doses of ofloxacin monotherapy. Was not included in the standard treatment protocol. Used in alternative regimens in case of rifampicin cannot be or to shorten the duration of treatment. Macrolide antibiotics like clarithromycin, this shows the less bactericidal than rifampicin. This 500 mg daily dose caused 99.9% bacteria killing in 8 weeks. Minocycline is a tetracycline category which is active against M. leprae. Its bactericidal activity is higher than that of clarithromycin. This is used in alternative multi-drug treatment regimens. Recently, thalidomide 50 to 100 mg capsule, this form is approved by FDA, is an immunomodulatory agent, is used in erythema nodosum leprosum, which is the complication of leprosy occurring in approximately 1/2 of borderline lepromatous and lepromatous leprosy patients. Next we come to this multi-drug therapy. This multi-drug therapy with rifampicin, dapsone, clofazimine, this combination was introduced by WHO in 1981. It can be used for all cases of leprosy. WHO 1998 recommends multi-drug therapy for leprosy in all patients, and this is also adopted in India 1999. Main advantages of multi-drug therapy: this effective with primary dapsone resistant case, prevents emergency of dapsone resistance and reduce the total duration of therapy, and this also affords quick symptom relief. This is the main important advantages of multi-drug therapy. Next come to this multi-drug therapy in multibacillary leprosy. Usually dapsone, rifampicin, clofazimine. This combination is used and duration of treatment is for 12 months. This is the child dose in case of multi-drug therapy. This rifampicin, clofazimine and dapsone. The duration of treatment in case of multibacillary leprosy was found to be reduced to 12 months as compared to earlier recommended duration of 24 months based on the similar relapse rate over a period of 3 to 5 years. Multi-drug therapy in paucibacillary leprosy, this rifampicin, dapsone, clofazimine, this combination is used and total duration of treatment is 6 months. Alternative regimens with clofazimine and OMC, that's the ofloxacin, minocycline and clarithromycin, this combination daily for 6 months, and 4 drug regimens are also used, this rifampicin, spafloxacin, clarithromycin and minocycline daily for 12 weeks. For single lesions paucibacillary leprosy, usually ROM regimens are used. This rifampicin, ofloxacin and minocycline. This given as single dose. Next come to this lepra reactions. Lepra reactions mainly occurs in lepromatous. It develops 4 to 6 weeks after dapsone treatment, is called Sulfone syndrome. This consists of fever, malaise, lymph node enlargement, jaundice and anemia. It is generally seen in malnourished patients. Drugs are thalidomide, chloroquine and prednisone. Reversal reaction, this mainly seen in tuberculosis, is manifestations of delayed hypersensitivity to M. leprae antigens. Cutaneous ulceration, multiple nerve involvement with pain and tenderness occur suddenly even after completion of therapy. Most preferred drugs are clofazimine or corticosteroids. Clofazimine and corticosteroids are effective in both types of lepra reaction. Chloroquine is effective in type 1 and thalidomide in type 2 reactions. This study demonstrated that prophylaxis with a single dose of rifampicin was 57% effective in preventing leprosy for the first 2 years in individuals who have close contact with newly diagnosed patients with leprosy. There is currently no widely used standard for using medications for the prevention of leprosy. Currently, there is no single commercial vaccine that confers complete immunity against leprosy. Several vaccines, this include BCG vaccines, provides protection against leprosy in certain populations. This ADSOP trial, this the bacterial cidal activity of daily dose of this antimicrobial therapy with pifloxacin, ofloxacin against M. leprae in humans. This pifloxacin versus ofloxacin versus ofloxacin, this dapsone and clofazimine for this treatment duration for 2 months 4 weeks. So this shows the total eradications of M. leprae. This eradicate the M. leprae. This 99% of eradications reported. This is the comparative bacterial cidal activity of various anti-leprosy drugs, mainly this fluoroquinolone antimicrobial therapies and rifampicin. This shows the good bacterial cidal activities in mice, both in mice and humans. Next we come to this, the new need for this, or the importance of newer drugs. Newer drugs are, in spite of these promising results of the WHO advocated, this multi-drug therapy is the need for the new anti-leprosy drugs is still immense. Some of the basics reasons for that are problems of existing drug resistance to components of the present multi-drug therapy has been reported since the 1960s, and dapsone was reported in 1964, rifampicin in 1976 and clofazimine in 1982. These are some newer drug regimens is fluoroquinolones category of ofloxacin, pifloxacin, sparfloxacin, temofloxacin, moxifloxacin and slafloxacin. Tetracyclines like minocycline, macrolide, clarithromycin, rifabutine, rifapentine, dihydrofolate reductase inhibitors, brodimorphin, fusidic acid, beta-lactam, antibiotics. Newer phenazine derivatives, these are the derivatives of clofazimine derived by halogenation of the parent drug para-aniline group at its 3-7 position. 7 new drugs in these categories are under trial both in vitro and in vivo. Compared to clofazimine, they are found to be more effective against M. leprae. This mouse foot pad studies also shows the favorable results when compared to clofazimine derivatives. Benzylamine, this is the N-methyl-3,5-dichlorobenzylamine hydrochloride in mouse foot pad, had shown strong synergism with good clinical response, tolerability at high dose studies in combination therapy with dapsone and rifampicin. They show the rapid development of resistance as monotherapy. This drug can form part of the combination regimen. Hydrozone carries thiacetazone is found to show very good synergism with rifampicin, dapsone and isoniazid by inhibiting bacterial ribonucleotide reductase to inhibit DNA synthesis. Side effects are mainly seen on the skin, liver and bone marrow. Dihydrofolate reductase inhibitors. These categories of drugs inhibit the conversion of dihydrofolate to tetrahydrofolate by inhibiting the enzyme dihydrofolate reductase. Included in these groups are this prodimorphin, epirovim, and is found to be effective both against dapsone sensitive and dapsone resistant M. leprae, and this also show the synergism with dapsone. Rifampicin derivatives is orally effective drugs that is acts by inhibiting DNA-dependent RNA synthesis. Rifabutin, rifapentine, there are some of these lots of derivatives are identified is found to be most bactericidal at lesser dose and is effective against rifampicin resistant strains also. Rifabutin, some derivatives also found to show synergism with ofloxacin. These drugs are potential implements for multi-drug treatment. Recently, this rifapentine has shown a high antileprosy activity when this given a single dose of 100 mg per kilogram in mice. This showed a 20 times more killing power than the single dose of 10 mg per kilogram of rifampicin. Next come to this the miscellaneous category is fusidic acid. This inhibits the protein synthesis by inhibiting to protein elongation factor G. This in vitro study shows the activity equal to or better than rifampicin, minocycline and ofloxacin. Some of these studies shows the effects of local treatment of nostrils with fusidic acid cream was investigated in 30 previously untreated lepromatous leprosy patients. This cream was applied in the nostrils after flushing the nostrils with normal saline twice a day for a period of 4 weeks. Next drug is Ducifone. This is the pyrimidine sulfone derivatives. This drug is developed in USSR, is found to complement dapsone action by increasing its bacterial killing, decreasing its side effects and decreasing reactional episodes. And this is T cell stimulation. Another drug is the deoxyfructose serotonin DFS. This is a human metabolite from serum extracts found to be bacteriostatic in vitro and in most food pad studies. Clinical trials in lepromatous leprosy patients showed the good clinical response by increasing bacillary clearance. This found to prevent nerve damage as a monotherapeutic agent. This shows the histological improvements also. This is the some of the newer regimens under trials. This efficacy of multiple monthly dose of ROM for this treatment of possibacillary multibacillary leprosy. This has been tested in the field trials in 3 different countries. 2 of the trials has been terminated prematurely, and this another combination of rifapentine, moxifloxacin and minocycline is currently being used in a short-term clinical trial in lepromatous leprosy patients. This combination of newer anti-leprosy drugs is clinical trials of combination of ofloxacin with dapsone, clofazimine and ofloxacin with RMP, this rifampicin, minocycline and pfloxacin have been reported to the beneficial in the treatment of lepromatous leprosy. So these are some assignment questions. This classify antileprotic drugs and the short note on lepra reaction. This in most of these previous university exams this frequently asking these questions about this short notes on lepra reactions. Okay, then what are the advantages of multi-drug therapy, and write down the role of antimicrobial therapy in leprosy, and then was the write down these combinations of newer anti-leprotic drugs. Okay, thank you so much for your patient listening.